Good afternoon, class. My name is Thomas Harvey, and I am doing the Module 4 video discussion post. I will apologize for my voice. I am getting over the flu, and I don't quite have the voice that I would have had in a different week if we were recording a video. Anyway, so I just want to talk a little bit about the background of this Module 4 discussion. So HG is a 28-year-old male that comes into the office for a chronic cough. He says that his coughs and wheezes are around 3 days a week and has symptoms 3 to 4 nights a month as well. This has been a problem on and off, he says, for approximately about a year. So spring and fall, it seems to be worse, so probably more seasonal. He also coughs more when he is exercising. He has been treated twice in the past year for bronchitis with antibiotics and cough suppressants, but he never seems to clear up completely. His examination is normal except for his lungs, which reveal expiratory wheezing, and has no allergies and is on no medications. You diagnose him with asthma. So the first question is, what severity of asthma does HG have? So when talking to HG, I would say, I've reviewed your health history, and I see that HG, that you have had you've had greater than 3 times of wheezing in a week. So that would put you in this severity of asthma category as mild, because it also follows a chart that I'm looking at that says 3 to 4 times a month, which also is congruent with your health history. And it would be more moderate to severe if it was greater, if it was like daily, and in more than 3 or 4 nights a month. So what medication would I prescribe? So for him, sometimes, so for HG, what I would prescribe him, or HG, I'd prescribe you like a short-acting beta agonist inhaler. So I could do an albuterol inhaler, which is for fast acting. But because of HG and your history of bronchitis, I think it'd be important that if I give you a fast acting inhaler, that it also has a corticoid steroid with it. And the corticoid steroid would just help more long-term maintenance for asthma, so you won't have as much constriction in the airways. So like a normal airway, as a demonstration, a normal airway is like this. I mean, you can see that it's patent, and that it's open, so with somebody that has asthma, your airway is more inflamed in the lining. So when you have like mucus buildup and inflammation, you can see that there is a barrier around the lumen of your airway. So it becomes more constricted over time. But when you're taking a inhaler with a corticoid steroid, it actually opens up that airway, so it's less constricted, and allows you to be able to breathe. So hopefully, those 3 or 4 nights a month, that would go away, but also it was mentioned in your health history, the exercise-induced asthma. So this inhaler specifically, the albuterol budesonide inhaled, it's also called Air Supra, so like specifically with this though, it's 2 puffs as needed for asthma symptoms, but not to exceed more than 12 puffs in a 24-hour period. So with an inhaler, you can see on the top piece here, might be hard to see on this little camera here, that you have 180 out of 200. So you still have quite a few doses left in this inhaler. So one thing that we encourage people to do is to shake it, and then you want to have your tongue flat, and then you want to inhale it, like this. So next thing I would say, we really are looking for long-term asthma management. So we want to prevent chronic symptoms, so that requires us using one of these short-acting inhalers, to maintain near normal levels of breathing, but also we want to reduce and prevent exacerbations. We want to minimize the need for emergency care and hospitalizations and really kind of prevent you from actually end up being on medications for bronchitis. So I want you to actually get one of these inhalers, and then I'm going to have you, I want you to be using it, but the next time we meet in about a week, I want you to demonstrate to me how you would use an inhaler. Thank you.